Good morning, guys. Happy 4th of July. Yes, and I'm working today. This right here is one of the downsides of working urgent care, because in primary care you work no holiday. Urgent care, you have to work holidays. So this is my first holiday in more than 5 years. Like, I have not worked a holiday in so long, because I wasn't like a full-time nurse even when I was going back to school. Even previously to that, so I wasn't really working any holidays, only if I chose to, but these are mandatory. Urgent care is actually going to be closed at 4 o'clock today, and that's something new that they implemented, because apparently I was told that before I started, this particular urgent care was open 7 days a week, 8 to 8. We know how these companies are. Greed. It's profit, you know. Healthcare is profit. So hey, so it's 7:15 right now. I'm just gonna make some tea, make some coffee, go on about my day. We're gonna try to vlog a day in the life working in an urgent care setting. Did I say I'm Laurie if you're new here? I always forget. My name is Laurie if you are new to the channel. Sorry. Yeah, let's do that. Let's speak it to existence. It's not going to be super busy today, because you never know, you know. I've been told by folks who work in the urgent care setting that sometimes the holidays are still busy. Like, people still, it's like a rush of people still coming in, which is crazy to me. So what's up, guys? So it's after 12 o'clock and I have seen a total of 9 patients. I actually have had 3 eye situation, so I think this educational content is going to be something about the eyes, because I had a very interesting case that came in. I'm gonna kind of do a little workup for that, but so far so good. No laceration or anything so far, no x-rays that I have to do so far. So for the urgent care setting, the only thing that we can really do, we have an x-ray machine and that's it. We don't have any more imaging. Of course, we're doing our standard COVID testing. People want to make sure they don't have COVID to go around their families. I have seen a couple of fireworks injury, because it's a lot of fireworks going on. So I did see 2 people so far with fireworks type injury, so be careful. I just wanted to check in real quick with you guys. Hello guys, I'm done working. So it is 4:05 and I just left the clinic. I am on my way home to go hang out with my sister and a couple of friends at her house. Today was a very good day. I learned my lesson, and I didn't say it was slow, even though it kind of was. I ended up seeing a total of 21 patients. I did an x-ray on 1 person. Majority of the cases that I was seeing today, I had 3 people come in with eye related issues, so I'm gonna do my case study in this video on that. And then I had 4 people with UTI type symptoms. So yeah, I hope you guys enjoyed this portion of the video, but I am going to get into the educational content right now. All right guys, so before I jump into the case study, I wanted to show you guys this urinalysis. I wanted to show you this one compared to one that I got the next day that I worked, and I thought this would be good to point out. So if you notice on this urinalysis, you notice that the leukocytes is 500, but the nitrate in this one is negative. And then in the other urinalysis, the nitrate is positive, leukocyte is 500. I have a video on my channel where I talk all about how to analyze and read your urinalysis, but I wanted to say the patient whose nitrate was negative. The patient was an elderly lady. She was over 80 years old and she had all the signs of a UTI. Of course, I treated her. Even though the nitrate is negative, she is elderly. So try to avoid macrobid in elderly patients. I know in the outcare setting, we tend to use a lot of macrobid on patients for suspected UTI, but just remember macrobid is on the Beers criteria for elderly patients. Okay, let's get into this case study. I had a 35-year-old male who presented with swelling to the left upper eyelid. The patient did say that he was treated 5 days prior for I hope I said that right, which is a sty, with erythromycin ointment 5 days prior, and he was told to use warm compresses to the eye. However, the patient presents today and saying that that was not helping. He stated that the lid is still increasing in the swelling. He did deny pain to the eye, he denied any discharge to the eye, and he denied any changes in his vision. Now let's get into these differentials. So I just think everything about what could be up with the eye. Hordeolum, which clearly is not. I even threw conjunctivitis in there, chalazion, xanthalmus, blepharitis. I did ask him if he have any crusting in the lashes. Periorbital cellulitis, which is also known as preseptal cellulitis, and then you also have orbital cellulitis. So I started assessing him, looking at his eye, and then I kind of touched the top of his eyelid. I noticed that it was warm to the touch, and in the back of my mind I'm thinking, why is this warm to the touch? So now I'm thinking, warm to the touch, it's red, and I go, what is warm to the touch and red a lot of times? So that's cellulitis. And I actually started researching, because let me tell you, I say this once and I will say this again, there's nothing wrong with doing some research. Diagnosis was periorbital cellulitis. The reason why he was not diagnosed with orbital cellulitis, I will get into that later, but let's talk about what periorbital cellulitis is. Periorbital or preseptal cellulitis is an infection of the anterior portion of the eyelid, not involving the orbit or other ocular structures. In contrast, orbital cellulitis is an infection involving the contents of the orbit. Now, with orbital cellulitis, typically the patient would have diplopia, visual impairment, and or pain with eye movement. My patient had none of those symptoms. Also, the swelling could have been an allergic reaction to a antibiotic. And remember, he was on erythromycin. I did not go that route because of all the other clinical presentation that I saw. All right, guys, so let's talk treatment. Treatment of choice is always empiric, and per UpToDate, the treatment is augmentin, and this is because of the organism that is typically the infecting cause of the preorbital cellulitis. You can use any of those other two on your screen, say if the patient is allergic. Now, if there is any break in the skin, if you see any abrasion, any insect bite, any blunt trauma, that is when the recommendation is double therapy, because of the possibility of MRSA, and augmentin is not active against MRSA, which would be your augmentin or ceftonir, plus you want to add your Bactrim or your clindamycin, and that's how you go about treating this. I did give the patient augmentin, and I did advise the patient that he needs to follow up with his primary care physician. And you also have to let the patient know that if this is getting worse and it's not improving within 24 to 48 hours, they really need to go to the hospital, because at that time they're failing outpatient therapy possibly, and they could need some imaging done to see what is going on, CT scan or otherwise. All right, guys, that is it. Let me know what you guys think. I hope you learned something, and I will talk to you guys in the next video.